Is it working?
Yeah.
Thanks. Dear Chairman, dear colleagues, so around 10 million people worldwide are blind because of corneal diseases, and corneal transplantation remains the main option to treat these patients. But anyway, search for human donor cornea substitutes is still quite important. There are two main reasons of it. The first one is worldwide shortage of human donor corneas for transplantation. Except the US, almost all countries are undersupplied, and Ukraine is not an exception in this case, with annual need of 3,000 corneas, and only 500 are usually collected. Another important reason is that high risk of donor cornea rejection in a number of pathologies exists, like chemical and thermal eye injuries, autoimmune diseases, previously failed corneal grafts, and others. Ukrainian ophthalmologist Vladimir Filatov performed one of the first corneal transplantation in human in 1912. He also first suggested the use of cadaver cornea for transplantation and elaborated first preservation methods, moist chamber. Later on, he founded Research Institute of Eye Diseases in Odessa, which has continued in the tradition to seek out technologies for treating complex transplantation cases. And more than 50,000 corneal transplantations were performed at the Institute after the Second World War. The first corneal substitute developed at the Institute was keratoplasty. During this period, original keratoplasty construction, we called it universal separable K-Pro, with optical part made of PMMA and support part made of tantalum, was developed. Original keratoplasty implantation methods as well as leukoma and keratoplasty strengthening methods were developed. There were two major developments besides keratoplasty construction itself, which allowed significantly improve outcomes of the surgery. The first one is two-stage methods of keratoplasty. The idea of the methods is to let K-Pro be well engrafted within corneal layers before being open. During the first stage, after division of cornea into anterior and posterior layers, only its posterior layers are trefined, where keratoplasty is placed, and then keratoplasty is covered by non-trefined anterior layers of cornea. And the second stage is performed in 3 to 5 months, and only corneal anterior layers over optical part of keratoplasty are trefined. This is an example of two-stage methods of K-Pro implantation. By the way, one of our older keratoplasty construction is implanted here with different design of support used until 1977. The second development was introduction of different leukoma strengthening methods to get safe keratoplasty fixation in patients' cornea. Different methods of corneal transplantation and different tissues are being applied for this aim. Epicorneal strengthening is performed 4 to 6 months before keratoplasty implantation. Donor cornea or patients' oral mucosa are used for this purpose. Upper figure shows the scheme of episcleral fixation of cornea or oral mucosa. Dashed line is limbus. Intracorneal strengthening is performed during keratoplasty implantation. Donor cornea or patient's ear cartilage or dura mater are used for this purpose. Ear cartilage gave the best K-Pro fixation in leukoma. Different combinations of these methods are also used. So this is main steps of the surgery. Usually it starts from the ear. After skin incision on the anterior surface, ear cartilage is separated. Then it is trefined with 10 mm trefine, and cartilage graft is cut with 3.3 mm trefine to adjust it for optical cylinder of keratoplasty. And then we move to cornea itself. This is leukoma strengthened with oral mucosa graft 6 months earlier. It is divided into layers from upper to lower limbus at the maximal possible depth. Then in this in optical part, the trefination 2.8 mm diameter is made. Through this incision, soft cataract can be removed. at the same time with the surgery, and after the opening and cataract extraction, if it exists, keratoplasty together with corneal cartilage graft is placed, and anterior layers is sutures in place, and keratoplasty later opened in 3 to 5 months after that. So during this period, at Filatov Institute, more than 1,000 patients were operated on with high-risk leukomas of different etiologies. These were mainly post-burn patients, patients after trauma, infectious keratitis, autoimmune diseases, and aphakickeratopathy and event surgery as well. Before keratoplasty, more than 90% of eyes had light perception, rest of the eyes had minimal vision. Both eyes were blind in 90% of patients, and period of blindness before K-Pro varied from 1 to 52 years. As a result of keratoplasty, different degree of vision was obtained in more than 96% of eyes, visual acuity more than 0.1 obtained in almost 70% of eyes. Different complications occurred in some patients in different terms after keratoplasty. The most threatening complication, keratoplasty extrusion, decreased from 17% during first years to 1.5% during last 15 years. Significant decrease of this complication was connected to introduction of essential combination of EP and intracorneal strengthening for each patient since 1995. Overall visual acuity loss because of extrusions and other complications like endophthalmitis, retinal detachment, secondary glaucoma occurred in 10% of patients in distant terms of follow-up. Other complications like retrokeratopathy membrane or mucosa overgrowth over K-Pro can be removed surgically or using the YAG laser for retrokeratopathy membrane. At last follow-up, vision of different degree preserved in majority of patients. Good keratoplasty fixation in cornea was obtained in 93% of operated eyes. Minimal follow-up for results presented is 1 year, and maximal follow-up at the moment we have patient with 40 years follow-up with keratoplasty still in place, and some vision is preserved. So this patient was from Serbia with pre-operative status of both eyes with both eyelids symblepharon and vascularized leukoma. After symblepharon repair with oral mucosa grafts, after first stage of keratoplasty implantation with simultaneous ear cartilage graft implantation, and after opening, visual acuity was 20 to 20 and it was preserved for 34 years. So keratoplasty with use of our technologies is an effective method of vision restoration in patients with leukomas unsuitable for optical corneal transplantation. But during last years, donor cornea shortage in Ukraine significantly increased, and number of extensive corneal ulceration recalcitrant to medical treatment increased as well, and sometimes surgeons even had neither donor cornea nor human amniotic membrane for tectonic grafting. That's why we have to come back to the idea of xenografting. First studies to adjust animal corneas for transplantation were initiated at Filatov Institute after the Second World War, but vast majority of xenocornea transplantation in animals failed due to extensive graft versus host disease. Recently, in collaboration with Ternopil Medical University, a project was started to study native porcine cornea as possible human donor cornea substitute. Influence of different preservation methods on porcine cornea structures and antigen properties was studied, and it was estimated that cryopreservation at 180 degrees Celsius with cryoprotector and subsequent lyophilization preserve porcine cornea structure and decreases antigen properties. In vivo experiment was studied to test cryo-lyophilized porcine cornea as possible human cornea substitute. More than 100 animals were operated on using intralamellar implantation and deep anterior lamellar keratoplasty techniques. Both clinical observations and light microscopy showed no cases of graft versus host disease in 12 months follow-up in cryo-lyophilized porcine cornea group, and 56% of animals was transplanted native porcine cornea developed graft versus host disease. After registration of medical product called keratoxina implant and getting approval from State Inspection Board on Drug Quality Control, phase 1 clinical trial was initiated. The purpose of this trial was to study safety and therapeutic efficiency of cryo-lyophilized porcine cornea transplantation in patients with corneal ulceration. Primary study point was to save patients' eye globe, and secondary were complications and visual acuity. 30 patients with corneal ulcers after grade 4 chemical burn and infectious keratitis were enrolled. Follow-up was 12 months, and operation methods was lamellar or full-thickness tectonic corneal grafting by Puchkovskaya. Depending on ulcer size and localization, different graft forms can be used. As a result, all eyes were saved, but 3 patients required additional conjunctival flap to get final corneal epithelialization. Graft lysis occurred in 2/3 of patients, and xenocorneal engraftment with opacity and vascularization occurred in 1/3 of patients. Visual acuity more than 0.01 was got in 12 patients. Complications occurred in 2 patients with chemical burn. It was acute inflammation reaction with subsequent lysis of the graft. So this patient with perforated bacterial corneal ulcer before. On the 7th day, after full thickness corneal xenotransplantation and 12 months follow-up, the graft lysed and vascularized leukoma was formed. And this patient with grade 4 chemical burn and total corneal ulcer and circular paralimbal conjunctiva necrosis on 14th day of lamellar corneal xenotransplantation, and in 12 months follow-up, the graft lysed and non-intensive leukoma formed and visual acuity improved to 0.12. And this is the first patient with xenocornea transplantation performed to save the eye globes and subsequent keratoplasty to restore vision. So this is before the surgery. It's after lamellar tectonic grafting with viable conjunctiva and tenons, flaps and tarsography on both eyes. This the patient status before and after left eye ankylosing blepharon repair with oral mucosa grafts, and after keratoplasty implantation in her left eye, and the visual acuity 0.9 was obtained. So first results of application of porcine corneal xenografts prepared using developed technology of preservation and storage in corneal ulcer treatment indicate on expedience of further clinical trials. So this xenograft might become cheap and long-term stored corneal substitutes for eye globe rescue if no human donor cornea and amniotic membrane available. And the latest development is bioengineered cell-free corneal substitute based on collagen cross-linking technology, which is developed in collaboration with Linkoping University in Sweden. What is done in this area at the moment? Fabrication technology is worked out. It should be type 1 or 3 collagen-based hydrogel with collagen concentration from 10% to 20. Collagen cross-linking and interpenetrating networks creation are being used to increase implant strength and biodegradation resistance. Optical, chemical properties and physical of these implants were similar to human cornea. When used as corneal substitute for transplantation, implants stimulated both corneal tissue and nerve regeneration in the experimental animals and in small group of patients with keratoconus, with no need for immunosuppression. However, these early implants had tensile strengths that were much weaker in comparison to the human cornea. That's why the implants were sutured to recipient cornea with overlying stitches in majority of cases, but not continuous or separate one as in conventional corneal transplantation. Almost transparent with single dirty air bubble inclusions implants were fabricated at Filatov Institute based on the cross-linking of collagen with carbodiamide. Our corneal substitutes had refractive indices similar to human cornea. They were elastic and strong enough to tolerate well placement of interrupted stitches during lamellar corneal transplantation performed on ex vivo porcine eyes. To overcome implant weakness, sutureless implantation method was developed for experiment in vivo. The implantation was performed as follows. Corneal incision 4/5 thickness in depth was made near the limbus. Then a corneal pocket was formed by blunt dissection. The implant was introduced into the corneal pocket with the use of the spatula. Corneal incision was closed with nylon sutures, and the superficial corneal layers over the implant were then removed using 5 mm Trefine. So, clinical evaluation showed no adverse inflammatory reaction. In all animals, during 1 year follow-up, full epithelial coverage over the implants was completed within the first week after the surgery. No neovascularization was observed in the implant location area. And when implanted into rabbit cornea, the corneal substitutes remained stably integrated and clear during 12 months follow-up. Light microscopy confirmed good integration of the implants within the rabbit corneas and absence of inflammation. Big advantage of bioengineered cornea is one can adjust it to specific purpose. For example, stem cells, growth factors, and drugs could be introduced to such implant during fabrication. We developed corneal substitute that served dual purpose of promoting corneal regeneration as an alternative to allograft transplantation and delivering anti-infective peptides as an alternative to antiviral drugs from within the corneal substitute to treat infection and to prevent new infection. Anti-infective peptide LL37, cathelicidin, a molecule of innate human immune system, was chosen for this project. It was encapsulated in silica nanoparticles under magnetic styrene, and particles with encapsulated peptide were then introduced in corneal substitutes during their fabrication. And antiviral properties of corneal substitutes were tested against type 1 herpes simplex virus in vitro. Gradual release of the peptide from within the implant was confirmed up to 3 weeks after. The developed composite corneal substitute showed no toxicity against human corneal epithelial cell compared to clear implants and drugs. The implants with embedded LS37 sustained delivery system show good activity against herpes simplex virus, which was confirmed by plaque formation assay and immunofluorescence analysis. And after getting approvals from Filatov Institute, Bioethics Committee, and State Inspection Board on Drug Quality Control, first-in-man clinical trial was initiated to study optimized collagen-based corneal substitutes in non-infectious corneal ulcer treatment. Primary endpoint of the trial is corneal ulcer healing. Secondary endpoints are complications and visual acuity. 10 patients will be enrolled and 4 already enrolled, and I will show the first results. Method of implantation is anterior lamellar keratoplasty with overlying sutures. So all implants were well tolerated, no inflammatory reactions were seen. Implants did not lyse and epithelialized within 2 to 8 weeks after the surgery. Visual acuity slightly improved compared to preoperative level in all patients. So this is the first patient with corneal ulcer 2 months after alkali burn, and in 1 year after corneal substitute transplantation, 5 mm implant with thickness 250 micrometers was used to substitute damaged stroma. Corneal surface restored and visual acuity improved. The next patient, again 2 months after alkali burn, non-healing ulcer, 1 week after corneal substitute transplantation. The implant is transparent and secured with overlying sutures, and 9 months post-op, non-intensive corneal opacity is formed and visual acuity improved to 0.17. Next patient with corneal ulcer developed after combined surgery, penetrating corneal graft plus cataract extraction and IOL implantation. 2 weeks post-op, 4 mm diameter implant, 250 micrometers thick was used. Transparent implant secured with overlying sutures and corneal haze on the implant posterior surface is seen. And in 6 months post-op, transparent implant covered with semi-transparent corneal epithelial and visual acuity improved. And the last patient with corneal stroma dystrophy and frequent recurrent erosions 3 years after burn. At the end of surgery, 350 micrometer thickness implant was used, and in 6 months, transparent implant is covered with conjunctivalized epithelium, but epithelial surface is stable. Therapeutic effect was good. No erosion recurrences were seen during this observation period. So first results of collagen-based biosynthetic corneal stroma substitute indicated on safety of the developed implants and their ability to withstand corneal ulceration and promote corneal surface restoration in non-infectious corneal ulcer patients. Further controlled clinical studies needed. In summary, I should say that due to the increasing worldwide shortage of human donor corneas, keratoplasty, corneal xenotransplantation, and regenerative medicine strategies using biosynthetic collagen implants developed and are being developed at the Filatov Institute allow preserve and restore vision in patients with very severe corneal disease. And on behalf of my colleagues and courses, I would like to thank you very much for your kind attention.
Thank you very much. We are running a little bit short of time, but we have time potentially for one question if anybody has a question. Thank you for such a wonderful presentation, and thank you for all the work that you're doing.